a discussion on blocking DHT between Dave and Kyle. Welcome back to the TRT and Hormone Optimization YouTube channel. And we have two guests today back with us. They both have been on the channel before. Welcome, Kyle Gillett and Dave Lee. Welcome, guys.
Thank you.
Thank you.
So today it was actually a topic that was an idea from one of the viewers on the channel, a discussion on blocking DHT between Dave and Kyle. So maybe Kyle, explain to us what are some good indications for blocking DHT? Why would you do it, and what's your experience with that?
Yeah, so a few basics starting out. DHT is dihydrotestosterone, as most people that listen to this channel are probably aware, and it is a stronger androgen than testosterone. You think about androgenic effects like the development of secondary sexual characteristics of androgen hormones like testosterone and DHT. Then you think about the anabolic effects as well. It's not a perfect dichotomy like that, but that's a reasonable way to think about it. And there's not really a way of, I guess, blocking DHT. Some people argue about semantics when it comes to lipids. So they'll say, well, don't call it LDL cholesterol because it's a lipoprotein. So I'm going to kind of do that in this case. And we can either talk about blocking the androgen receptor, or we can talk about blocking the conversion of testosterone to DHT. So what the commenter had wanted us to talk about, mostly we can go into whatever rabbit trail conversation leads, but specifically talking about blocking an enzyme called 5-alpha reductase. There's 3 of them that we currently know. We used to know of 2 of them. And there's a couple different medications like finasteride and dutasteride. And there's also a lot of supplements that also block these enzymes in various strengths and ratios. So we can start off with a few things that we would mostly agree on is that in most cases, for males and for females, you don't want to do things that block the androgen receptor unless you absolutely have to. Metastatic high-grade, high Gleason score, which is just aggressive, prostate cancer is sometimes one of those reasons. And then you can block it in various tissues with SARMs as well. And then we can also start with something else that we would also probably agree with is you want to think about each individual cell as a part of physiology together and independently. The word for this is intrachronology, because when you're talking about 5-alpha reductase inhibitors, you're not really talking about blood DHT levels or serum DHT levels. You're thinking about its effect in each organ system in the body.
All right. Dave?
Yeah, so firstly, big thank you to Kyle for coming on and talking about this. I know that a lot of people have been wanting to hear, I guess, a informed and respectful conversation from both sides of the fence. I find that that is often a paradigm that is immensely lacking in many online communities. And I think the value that people are going to be able to take away from this is to be able to have an informed opinion about a medication they may already be taking or may be thinking about taking. And I think if the recent years have taught us anything, it's the importance of informed consent when it comes to taking medications. And I try not to be dogmatic in approaches, but I'm a little bit dogmatic on this approach, but I'm also of the stance, firm beliefs held loosely as opposed to loose beliefs held firmly, which I think a lot of people have. I am very open to changing my mind. Recently, I had a great topic with a memo from Marek Health about the potential use cases for enclomiphene, and I was actually convinced on that, which was something that I've been quite, I guess, ignorant to in terms of to use a correct term for that. So my approach for, I guess, the nuance when it comes to discussing 5-alpha reductase inhibitors, I would argue there's probably 3 potential use cases for them. One is around hair loss, preventing hair loss, which I think most people on the channel are probably going to be looking at. The second would be as a prostate cancer prophylaxis. And then the third would be for treating prostate cancer that has already been developed. I have very little understanding, and I would argue no place talking about the third. It's not in my wheelhouse, and I'm not going to pretend that it is. I think it's very unbecoming when people speak outside of their lane, so I don't want to do the same thing. My, I guess, perspective on DHT, and I'm going to start this actually when we I need to grab my phone to do that. I was devastated when I lost my hair. It was one of the most difficult things I went through in my early 20s, but it certainly wasn't one of the most difficult things I went through in my life. At the time it was, though, because I was very young. I was in a band, I had long hair, I used to straighten it and dye it. I cried the day I went to the barber and had to shave it off. It was very difficult. So for people who have the perspective that, you know, some people are more attached to their hair than others, I was very attached to mine. And I'll send Stephen some videos you can, photos maybe you can put up on the screen. So I think that when guys are looking at using a 5-alpha reductase inhibitor to block 5-alpha reductase, which doesn't just block the production of DHT, it also 5-alpha reductase does other things in the body. It's important for degrading cortisol into dihydrocortisol so it can be eliminated. It's important for the production of allopregnanolone, as well as the metabolites of DHT, which is 3A, I'm probably pronouncing this wrong, androstenediol, and 3B androstenediol as well, which all have important biological functions. And I would like people to be able to make the informed decision as to whether the benefit of keeping their hair for the cosmetic and potential psychological implications that come with that, it's an uncomfortable thing to go through, hair loss, is worth the potential ramifications and repercussions for their biological health, potentially if there can be issues where after discontinuing the medication, the side effects may not resolve, which is this syndrome known as post-finasteride syndrome, which some people debate about. I guess the most important kind of overarching point that I would like to address today is that my concern is that if someone doesn't have acute effects from using a 5-alpha reductase inhibitor for hair loss, let's say they're like, well, my libido is good, like, you know, I don't really have any problems. Is that potentially going to lead to health ramifications long-term that they might not be aware of, you know, things happening now that could be causing problems downstream? I think that's worth looking at. And I guess overall, the importance of guys understanding what the prevalence of these side effects are, what the different percentages are in terms of how often they come up. I've seen some people say it's 1%, 2% of guys get side effects. In some studies, it's up to 15% get erectile dysfunction. But the other side of the coin, and Kyle did a great video the other day on GLP-1. And he said, he gave this perspective of saying, well, if there are risks to using GLP-1s, those risks are likely outweighed by the benefits of resolving obesity due to the risks that come with obesity in these contexts. And I think that that's a very valid counter argument for using pharmaceuticals. I would just be concerned that healthy men be sabotaging their health and for the sake of something that's not actually life-threatening, that's just psychologically uncomfortable. So that's my perspective on that. And then I also, I guess, question whether the benefit of blocking 5-alpha reductase for the potential development of prostate cancer is warranted, and if it is as beneficial as stated. And we can go through the trials which they have assessed that.
Mm-hmm. Yeah, on the channel we have discussed with several people this post-finasteride syndrome. With a lot of long-term side effects and ramifications for them. But yeah, Carl, you prescribe it for men with hair loss. You still do. I don't dare to prescribe it anymore.
Yeah, rarely I will prescribe finasteride in some cases, but for most individuals, I prescribe oral dutasteride or topical dutasteride, and often there's benefits other than hair loss. For example, they might be on a non-physiologic androgen regimen, which all androgen regimens, including testosterone creams and gels, are non-physiologic, unless someone's applying the cream as you sleep. But occasionally there is a secondary benefit. For example, less DHT driving erythrocytosis, or less DHT driving left ventricular or right ventricular hypertrophy, or the prostate benefits that we have previously mentioned. But the way that I prescribe it, I don't know if you guys are familiar with bipolar androgen therapy.
No.
Bipolar androgen therapy is used for castration-resistant prostate cancer, which is kind of like inverse finasteride or dutasteride syndrome, where there's a patient that has prostate cancer, they've been chemically castrated, and perhaps they've even taken an adrenal steroidogenesis cascade inhibitor as well, and it has continued to progress. And they actually use supraphysiologic doses of androgens, like a steroid cycle. And a lot of the same phenomenon happens that you see in males that take steroid cycles. They take 400 milligrams, and then and they actually continue to give them 400 milligrams of usually testosterone cypionate or enanthate, so half-life a little less than a week. And they give them one intramuscular injection every 28 days. So they purposefully spike up the testosterone and DHT supraphysiologically, even in patients with prostate cancer. And they continue to do that until there is progression of disease because of the androgens. So they've resensitized this patient's tissue, prostate tissue in this case, but other genitourinary syndrome tissues can be resensitized, as we do in patients. I think we all take care of, or at least Dave and I take care of a lot of patients with post-finasteride syndrome, as we do similarly in those cases in various ways. And then as soon as there's progression, then they end the bipolar androgen therapy. So you can do it the opposite way. Rather than give them supraphysiologic androgens, let's say there's a patient that is on, they've discussed with their physician the risk and the benefits of a higher than physiologic range testosterone replacement protocol. For example, 200 milligrams of cream or gel per day, or 200 milligrams of injectable or subcutaneous testosterone per week. And they want to attenuate some of those side effects because they are having benefits. Let's say their profession requires them to continue to do so. Maybe they're a strongman competitor. And for the same reason why you do the shared decision-making process, which is the same way I approach it, risk and benefits, as Dave mentioned. The same way that you have that conversation regarding their testosterone replacement therapy or the various options regarding it, you have that same conversation regarding adding in a 5-alpha reductase inhibitor. Maybe it is, maybe it's one pill once a week, and then you take a month off. That's your, 1 month on, 1 month off. And then during the month off, that's kind of your, or 2 weeks off. That's where your total androgenic load, or androgen pool, as I call it, is quite high. And then you're resensitized purposely to androgens during that point.
Mm-hmm. What do you think, Dave? Could Kyle convince you to advise men to take a DHT blocker again?
When I've reviewed, I think one of the limitations that we have in most fields regarding relatively novel pharmaceuticals is that we don't have lifelong or more than 10-year follow-up studies where they look at a guy's overall health outcomes. We tend to look at a couple of variables over a couple of years, or we look at a couple of variables over 10 years, but it's not like we're running these comprehensive health panels and doing this thorough investigation as to what happens. And I think one of the contested points in the hormone replacement therapy space is DHT as a paracrine hormone and the impact of circulating DHT on prostate cells. There's a study titled "Dihydrotestosterone Administration Does Not Increase Intraprostatic Androgen Concentrations or Alter Prostate Androgen Action in Healthy Men," a randomized control trial, if people want to look it up. Essentially, it was double-blind, randomized, placebo-controlled. They took 31 healthy men between 35 and 55, and they gave them supraphysiological DHT levels by gel. So 7-fold increase to baseline levels. And the findings were, quote, robust supraphysiological increases in serum DHT associated with decreased serum testosterone, because they didn't give them testosterone as well, just DHT, so it shut down estrogen production. Do not significantly alter intraprostatic levels of DHT, testosterone, or prostate epithelial cell androgen-regulated gene expression in healthy men.
That's because their SHBG decreased. SHBG delivers androgens into the prostate. So if you give a DHT gel, it'll bind to the liver first, decrease SHBG production, and not be delivered to the prostate.
Does it decrease it down to the point that it wouldn't deliver any to the prostate, though?
At least a non-inferior or non-statistically significant amount. I doubt the prostate shrunk. If you also account for the confounding variable of CAG repeat number and the androgen receptor, then that will also help stratify the data. In fact, you can go off PSA and prostate size if you start a patient on really any TRT regimen, and assuming you don't have them on any sort of anti-androgen, the increase in PSA and prostate size is very closely directly correlated with their CAG repeat number. So if both double, it's extremely likely that they're very sensitive to androgens.
And this is where, and this is one of the, it's a great example of that almost all studies are flawed in some way because of exactly what I mentioned before and what Kyle mentioned there, these mechanisms. But I guess in terms of, and this is why I really like the study of science. And this is where I think, you know, like ourselves, and I would hope people watching can appreciate the point of science is not to worship it like a religion. It's to use it as a tool to help us understand how the world works. And, you know, when I look at a paper, this was only a 4-week trial. I have seen men with, you know, 7-fold increases in DHT using bioidentical DHT, anabolic androgenic steroids. And I would argue that there would still be enough SHBG to at least impact the prostate. The fact that there was no change whatsoever in the prostatic environment, as well as other research suggesting that the prostate androgen receptors saturated at a very low level, I would, I guess, question the hypothesis or notion that modulating DHT levels via using something like dutasteride or finasteride on hormone replacement therapy would be beneficial. The other point that I'd like to reference as well is regarding DHT levels as well as survivability when it comes to prostate cancer. There's research showing that lower DHT levels lead to lower survivability outcomes in terms of it increases the mortality rate of prostate cancer. And I guess coming back to the original point that I was looking at, and I'm a little bit biased because I operate from this paradigm that I don't think healthy people should take pharmaceuticals, but that's just a perspective and approach, and there's obviously exceptions to this. And when I talk about pharmaceuticals, I mean bioidentical hormones don't fall into that category. And it's because I operate from this paradigm of guilty until proven innocent, and which, you know, I think is a good paradigm to operate on when it comes to things that are synthetic. But, you know, people can disagree on that, and in certain contexts, the benefits outweigh the risks, you know, particularly if it's life-threatening. I guess my concern would be that if we look at the other implications of reducing or lowering DHT in the cell, because my understanding of using finasteride therapeutically for something like prostate cancer is that because it's impacting 5-alpha reductase at a cellular level, it's reducing the conversion in every cell, which is leading to a more effective, if that's the goal, it's more effective at reducing the levels because it's not only working on the circulating levels, it's working on the intracellular conversion. So I guess I would be wondering if the long-term ramifications of things like the effect on insulin sensitivity, the conjected and potential impacts on things like neurodegeneration and development of Alzheimer's, potential impacts on the thyroid, increase in cortisol, as well as the thing that we're very well aware of, which is the correlation between depression, anxiety, sexual dysfunction, as well as gut dysbiosis, which is now a relatively newly identified phenomenon, arguably due to the impact on allopregnanolone. If overall it's going to be a net positive or a net negative for someone who's healthy. And I guess that's this kind of overarching kind of paradigm that I'm going to keep circling back to, is that if someone's not in a risk factor for a certain disease, and I guess it would be saying, well, if they're on TRT, does that put them into a risk factor case for prostate cancer, which is, I guess, what Kyle's argument is.
Not so much prostate cancer, but erythrocytosis and left ventricular hypertrophy and increased thromboxane A2 activity. Yeah, I think a point of agreement that we can certainly make, I always like to start from points of agreement, and then you can sort out the nuances, that telemedicine clinics should certainly not be prescribing finasteride with or without labs, really. It's really a nuanced drug. And I can also agree that if it's solely for cosmetic reasons, then young, healthy people, or even middle-aged healthy people, should also not be taking 5-alpha reductase inhibitors. And I think the same could be said of TRT. If they're young, healthy, with good testosterone levels, if they're only taking it for aesthetic reasons, they probably shouldn't take replacement medication or 5-alpha reductase inhibitors. The other point with topical DHT is topical DHT is probably safer than topical testosterone from a prostate standpoint, but perhaps not from a hematopoiesis standpoint or a hypertrophic cardiovascular disease standpoint, partly because testosterone, of course, also aromatizes. And if you give DHT, it decreases the aromatization of the estrogen. And the people who tend to be the highest risk of the highest grade prostate cancers, again, Gleason score, not to persever into the prostate, but that's just literally where we have the most clinical data, is they have a skewed ratio, part of which is genetic, of estradiol alpha to estradiol beta, two of the many receptors that estrogen binds to. So if you have less estrogen binding to that, then DHT actually might be a promising treatment for lower grade prostate cancers, not as promising as SARMs like enobosarm, in my opinion. But perhaps combined with enobosarm, you use DHT for the androgenic and sexual health benefits, and also to suppress testosterone when you don't want to go on full androgen deprivation therapy, and then add in a well-tolerated SARM for the anabolic benefits that DHT might not give you. One other point with that is the daily finasteride and dutasteride are also, and I'm kind of making Dave's point for him, daily finasteride and dutasteride have both been associated with decreased incidences of low-grade prostate cancer, but significantly increased incidences of high-grade prostate cancer. So you certainly don't want to take both of them continuously where your androgen pool is particularly drained. And then again, you're going to get more estrogen, probably 10 to 20% if you're on daily administration. So I'm certainly a fan of the pulse dose for those reasons. And then finally, the 3 isoenzymes that we mentioned earlier, one reason that dutasteride likely is far preferred to finasteride is 50 times stronger on type 3 5-alpha reductase. I can send the chart. I've posted it in a previous podcast at some point. And type 3 is almost always upregulated when you do have that disease state start. So maybe there's not excess tissue growth. I guess maybe we should talk about the brain, because there's actually really similar changes in the prefrontal cortex of people's brains. And you don't want to upregulate that type 3 5-alpha reductase. That's one of the theories why you can develop more manic symptoms. You think about, someone in the special forces comes home, they have a little PTSD, they have muscle wasting, they've worked hard and, served their overlords for better or for worse. And then they come back and instead of doing, maybe some ketamine therapy or whatever, counseling, they take a whole bunch of anabolic steroids. And then that kickstarts a manic episode, which is probably related to that same process, just in the prefrontal cortex, which is the decision-making part of the brain.
Mm-hmm. Yeah. I'll just elaborate more on a couple of points that Kyle made there. And so firstly, when he was talking about the reduction in low-grade prostate cancer and the increase in severe prostate cancer, there's 2 trials, one on finasteride and one on dutasteride, which are like these big long-term. So if people want to look it up, the finasteride one's called the prostate cancer prevention trial, and then the dutasteride one's called the reduce trial. Similar kind of outcomes in both. The thing that I think is interesting when people are talking about data is that what these studies found was about I think it's about a 30%, give or take off the top of my head, reduction in prostate cancer from finasteride. But what I think people also need to look at is that that's a difference between 10% and 15% when you're comparing placebo to intervention. So the first one sounds like way more significant, whereas the second one's like, well, that's not actually that big of a change. So data can be misconstrued when it's looked at in a certain way. But what they found in the reduce trial was that there was about so it's 24.8, so we'll call it 25% reduction in the incidence of prostate cancer with the 5-alpha reductase inhibitor. But then there was a 25% increase in high-grade Gleason cell tumors. So it was kind of like being like, well, there's less chance of getting it, but then if you get it, it's going to be more severe. And then the other thing that's been interesting to look at is how it impacted mortality long term. And there's some different data suggesting that it didn't make a difference, and then there's some other studies suggesting that there's reduced mortality when it comes to lower androgen levels and so forth. So that's that point. The point about PTSD is very interesting, and I completely agree that if you are going to come with someone who's got PTSD, they've likely also got, and Dr. Mark Gordon talks about this fantastically, the importance of looking at pregnenolone and DHEA and these other neurosteroids in veteran-induced PTSD when there's trauma to the head. If you come in and then upregulate androgen production massively, especially if you use these non-bioidentical anabolic steroids, you create this basically environment, exactly what Kyle said, that's going to induce mania because you're massively upregulating excitatory neurotransmission. And this is a huge detriment to these guys because, particularly if someone has got PTSD and their mental health's not good, they're more likely to take, how do I put this without getting banned? Long-term solutions for short-term problems, we'll say. So all of that stuff is completely correct. And the thing that I think that's interesting that Kyle's brought up, which, like we both mentioned before that we hadn't heard of, is this idea of if something is going to be used, this pulsatile approach is important. And when we look at these studies that's showing the detriments, particularly when we look at in rats in finasteride, they're injecting them with the equivalent of taking like a whole packet at once and then injecting that. The doses they're using are just insane. And I would argue that if you injected paracetamol at that dose, you'd probably cause any kind of issue as well. I mean, there's very few things you could inject that much of and not cause a problem. So a lot of the research when it comes to these things is not using the kind of dosing that Kyle is talking about. And I think this is why these discussions are so important, is for the sake of nuance. I guess the question I'd like to ask Kyle, because I know that this is going to be the thing that a lot of people are going to be asking about, and this is the bit that Stephen will probably clip. If a gentleman comes to you, like let's say hypothetically, on TRT or aren't on TRT, if there's a difference with those, please elaborate, who's started to progress with hair loss, let's say mid-20s, and they're wanting to take some form of 5-alpha reductase inhibitor or a combination with something like topical minoxidil or whatever. What are your, what's your perspective, approach, recommendations on that in terms of if they did do that, what kind of protocol would that look like? Because I'm assuming for hair loss, does that pulsatile approach, is that still efficacious?
Yeah, that's a good question. So the first question is the same question I'd ask if they came in and asked and said, hey, doc, how about some TRT? I would say, what benefits are you looking to get from this? And then what have you been experiencing, or how has your life changed or may potentially change that you can look out of it? And depending on the age of the patient, let's say they're a 20-year-old, I'm probably just going to tell them right off the start that it's pretty much almost no matter what, the benefit is not going to outweigh the risk in a 20-year-old. So they can look at other options. And I know we mentioned, DHT inhibitors or androgen receptor blockers. There are lots of promising candidates that we've gone into that for the purpose of this discussion, we don't have to. Maybe they look at a topical version of one of those that is not systemically absorbed. Topical finasteride is systemically absorbed significantly, and topical dutasteride is minimally systemically absorbed. It's very lipophilic, although it has kind of a borderline particle size, but it can certainly be systemically absorbed quite a bit. So you have to be really careful with the 1% formulations, because if you apply 1% every single day, it will be absorbed, which if you're not against some systemic absorption, that's okay. But then are you really going to pulse your topical? It's getting pretty complicated. But you can use topical dutasteride because of something called a dose-dependent half-life. Same thing as Tylenol, same thing as aspirin, where you have a different order pharmacokinetics. So basically how the body breaks down each drug, whether it's regardless of what molecule it is, your body's going to break it down in one or multiple ways. And after it reaches a saturation point, it's going to break it down very slowly. Example of this, if you take 2.5 milligram capsules of dutasteride every day, its half-life is going to be at least 12 weeks. if you take one 40 milligram dose, which is the highest dose I've seen it studied in humans, then its half-life is going to be even longer than 12 weeks. But if you take a very minimal amount, and again, talk to your doctor about the concentration, but in general, 0.25% or less. I do like to prescribe the 1%, but then you dilute it with other things and then apply, let's say, half of a milliliter just in the areas that most need it. A tiny bit, but a clinically insignificant amount is systemically absorbed. And before it's circulated, it has already been broken down because it's broken down very quickly in very low doses. So it is difficult, and most, if you're just getting topical dutasteride or finasteride, then it's probably been prescribed too high, and you almost might as well be on the orals. But I do like topical dutasteride regimens for some individuals. But to be safe, for cases, for example, let's say you're desiring fertility, then I also recommend not even taking topical dutasteride during that case. And then if you're on oral dutasteride, again, kind of similar to TRT, if the aesthetic benefit is a bonus, then great, we'll kind of add that to that side of the scale. But there should really be other benefits that you're looking for, which are far more rare if you're not on a TRT protocol.
Mm-hmm. And what would those other benefits be?
Of taking a 5-alpha reductase inhibitor, it would be if your androgen pool is high in basically any other organ system in the body, your prefrontal cortex, your liver, cardiac tissue. Skin is mostly an aesthetic benefit, but there is some benefit to it. And prostate tissue, you could probably find a few other examples. But in general, it would be decreasing the androgenicity of your either extremely naturally high testosterone. Some people do have it. It's relatively rare. There's actually a pretty big YouTuber that is currently being worked up publicly. But he's not a patient of mine, otherwise I obviously couldn't talk about it. But he's publicly being worked up for extremely high natural testosterone levels. I want to say 2,500 total, over 2,000. So they were concerned for a tumor that was producing it. His YouTube channel starts with an S, and he's a pyromaniac, which kind of makes sense. But anyway, it is rare, but it does happen.
It reminds me of that movie. I can't remember what it's called, but it's when the guy climbs the El Capitan mountain, and he's free climbing it, and then they looked at his brain, and he didn't have any receptors for cortisol in his brain. I was like, well, that makes sense. Interesting. Of course, he's a pyromaniac. So I want to give a bit more context for people watching, and then I want to ask you a follow-up question because I think this is fascinating. So for those who aren't familiar, there was a lawsuit against the manufacturers of finasteride, which is Merck, and this was in 2016. If people want to read about it, I don't know if I'm pronouncing this right, Reuters. I'm going to call it Reuters. That's probably wrong. I don't care. Yeah. But the title is Court Let Merck Hide Secrets About a Popular Drugs Risk, if people want to Google it. And you can actually read this section of the transcript. And what the prosecutor says is, quote, so you knew internally that these sexual adverse effects were prolonged or lengthened or never went away, and that is something that would impact sales in a negative way, right? And the answer was yes. Of course, the defendant's lawyer objected to the question, but it was sustained. So this was basically a class action against finasteride for this post-finasteride syndrome, which the company lost and had to pay out. It was $4.3 million. And since then, they've had to alter the package insert to say that side effects will resolve to side effects may resolve, which is, we'll leave that for another day in terms of how the pharmaceutical business works. So I guess my follow-up question to that, which I find this fascinating. So is the proposition that because dutasteride is significantly less systemically absorbed topically than finasteride, a little bit still goes in, but significantly less because of the structure of the molecule. And what you're also suggesting, because I don't work with it whatsoever, but it wouldn't surprise me that the doses being used on average would be far too high because of the amount of nuance in this. I guess what I'm questioning is, and I don't want to make this like a a black and white question, but this is kind of the questions that I think people are going to have. So I'd like to ask it. Would the idea be that obviously using topical dutasteride versus topical finasteride, let's say if you had a probability of developing side effects and permanent side effects, is the argument that, I guess the argument that most people agree on is that dutasteride will have a lower risk than finasteride if an appropriate dose is used. And then I guess the question that I'm saying is, if someone is using this like absolute minimal effective dose of dutasteride in the kind of dosing regimen that you're talking about and the form that you're talking about, I'm sure that you couldn't say that, and obviously you can't say we could guarantee that you could never get post-finasteride syndrome from that. But I guess the question is, would the odds be so significantly reduced that it becomes a virtually non-risk factor, or such a low risk factor that it's not worth worrying about, or significantly less to worry about, would be my question.
Yeah, it's a good question. Of the relatively large number of patients I've had on oral and topical dutasteride, including patients with post-finasteride syndrome, and because it can be used to treat post-finasteride syndrome, because it's essentially, I mean, it's not exactly the opposite of finasteride, but it is about 50 times stronger on enzyme type 3, and it's about 11 times stronger on enzyme type 1, and finasteride is at least 4 times stronger on enzyme type 2. So let's say you decrease the dose by 10x of the dutasteride, which is kind of what we did. It's about the same on type 1. And I can also send you a chart where you can put up where the enzymes are concentrated to make it more complicated. It's not like the prostate is pure type 3 and hair is pure, and the hair follicle is pure type 2, and pubic skin is pure type 2, and non-pubic skin is pure type 1. But we can send that just for reference, but it's a bit esoteric. I guess to answer the question more directly is side effects still do happen. If let's say someone's on a pretty high dose of topical dutasteride or a moderate dose of oral dutasteride, then often they get side effects like low libido. I haven't seen OCD or a lot of the mental side effects other than libido and drive, where I have seen those with finasteride. Not necessarily inducing a true OCD disorder, but moving someone further to the spectrum. Maybe it's technically more OCPD, be the classification, and then that can resolve. So don't really see that with dutasteride, but side effects certainly do occur. But the incidence of side effects, as you mentioned, is low enough to where treatment is reasonable in a lot of individuals, especially individuals on TRT. And especially females too. I know we're concentrated on TRT in males, but that's kind of a whole nother discussion, which maybe we do have at some point. That would be fun.
Yeah, this is fascinating, because I think one thing that I guess haven't articulated well in my critical stance of finasteride is that, and I like to relate this to I'm going to use the vegan argument as an example, and I don't endorse a plant-based diet, but I think there's a big difference between someone sitting here who's a vegan saying, this is why you shouldn't eat meat, versus coming up to them in a restaurant and taking the meat off the plate. It's two very different things. So I think when I'm saying, people shouldn't be taking this, it's like, you can do whatever you want. I mean, it's just an opinion, and it's a perspective. But I think the most important thing is that for guys who are going to go, hey, I recognize that there's risks here, because I think with all medical interventions, there are risks, especially things like surgeries and TRT as well. None of these are perfect solutions. They're all imperfect solutions. And I'm sure that they'll get better as time goes on. I'm sure hopefully one day we'll find a way to do TRT without shutting down natural production. And I think the most important thing for guys who are going to be like, hey, I'm going to do this anyway. Like, I had a client the other day he's like, I'm a model. I'm a career model. Like, I can't lose my hair. And I'm like there are instances where it's like, okay, we have situations where something has to be done. I think it's so important that rather than being like, never do anything ever, being like, if you are going to do something, then this is what you should do due to XYZ reasons, and reducing increasing the reward and reducing the risk in terms of the ratio between the two, as long as there's that understanding that there is still a risk and so forth. You brought up the behavioral components of the 5-alpha reductase inhibition, particularly high levels systemically in the brain. And I'm quite interested in neurosteroids because I previously had a brain injury, so it was a big part of my recovery. And I find it interesting when, when I speak to people who are very pro finasteride and often quite belligerent, I find it interesting when I look at the mechanisms and try to kind of correlate this between the behavior. And it's like, well, correlation, causation, and so forth. But I find it interesting that the two metabolites of DHT, which would then be reduced, not only promote GABA A receptor activity, which is what benzodiazepines and alcohol work on for those who aren't familiar with GABA A. It's your main inhibitory neurotransmitter, as well as allopregnanolone. But when we look at the 3B version of androstenedione, it also is responsible for oxytocin regulation. And I think if we look at that, as well as the potential down regulation of cortisol metabolism, someone's more stressed, less oxytocin, less GABA, I think that would lead behaviorally to the kind of tendencies that you talked about, as well as increased anxiety. And then people are arguing that this is also what's causing the issues in the gut, which could be then having the feedback with the brain and so forth. So that stuff all makes a lot of sense. A couple of other questions that I have personally, and I guess that other people would have. When it comes to post-finasteride syndrome, I haven't found personally, and again, I haven't been working with these, like, I guess I'll call like microdose of topical dutasteride that you're talking about. And I'm sure that when I inherit people who've been using it, they're probably using a lot more. Do you think, and again, I've looked into this and no one knows, so it's all opinion based. Do you think that it's a dose threshold that causes an issue, whether it's from time medicated or threshold, peak concentrations? Or do you think it's like a genetic interaction that some people, like, why do you think some people get this and some people don't?
I don't think there's a specific dose threshold. There's a lot of interesting effects of both neurosteroid androgens and progestogens, which are basically just downstream of testosterone, DHT, and downstream of progesterone. Pregnenolone can convert some to progesterone, which converts to 5-alpha reduced and 5-alpha and 3-alpha reduced progestogen, as you mentioned, which is just the same thing as allopregnanolone and isoallopregnanolone. But if you look at males and their testosterone levels, many people that have a total T of 250 have no symptoms whatsoever. And there are also males that have a much higher testosterone levels that do have hypogonadal symptoms. So there's a lot more genetic variability. So there's not a specific threshold. I think of that as the terrain. And if we dial into the central nervous system, the terrain in everyone is different. Some people are more mountainous. It's easier to dam up. And what 5-alpha reductase inhibitors do in different ways is dam up different valleys. So finasteride mostly dams up the type 2 isoenzyme valley, and dutasteride mostly dams up the type 1. Oddly enough, so when you take an oral capsule, it goes through the liver, kind of first pass metabolism. And that's where a lot of 5-alpha reduction happens. That's why oral progesterone and pregnenolone are both 5-alpha reduced in the liver. And why oral pregnenolone supplementation, we do know that it leads to higher levels of neurosteroid progestogens in the CSF fluid, which is the fluid around the spine of the brain. So you'd think that dutasteride is stronger, but even at a relatively high dose, dutasteride in animal models did not lead to as much lowering as finasteride, which is interesting. So if you use even lower amounts of dutasteride, that dam is not so high to where you completely dry out things and then make that territory of the brain hypersensitive to your neurosteroid androgens and neurosteroid progestogens. And a lot of people mention EGF when it comes to bodybuilding and DHT, because there's studies where DHT activates EGF, just how 5-alpha and 3-alpha reduced, if you look at the progestogens, one of them is going to activate GABA A, and one of them actually inactivates GABA A. So I think of allopregnanolone and isoallopregnanolone similar to T3 and reverse T3. However, you have with T4, you can just form T3 or reverse T3 without going through one. With progesterone, you have to 5-alpha reduce one of them. You can't 5-alpha reduce and 3-alpha reduce at the same time. There has to be a stepwise progression. So the first dam to get over when it comes to neurosteroid progestins, if you slowly dam up those progestins and then you let those progestogens through from time to time, periodically, then you're not going to dry out and change the territory of whatever your genetic terrain is, regardless of how high that terrain is genetically to get over. And then to your other point, at the end of the day, we are organic machines, kind of regardless of what your spiritual or metaphysical self-actualization thoughts are. So I think it is reasonable to try our best to get an idea of how our organic machines are made. Just like, and this is, I think everything you said was spot on, by the way. I really liked how you said there's a difference between the vegans telling other people to do something, and just like someone that has, a car hobby, they might say, everyone should put a turbocharger and nitrous on their car because it's literally better, and just get your labs and go to the mechanic, and there's going to be nothing bad that happens. It's just a little bit of money. And they say everyone should have a spoiler and they should have a new paint job on their car. And it's kind of the same thing when it comes to hair and aesthetics. It's like a car hobbyist arguing about whether or not you need a paint job or don't need a paint job. So I think that's a reasonable approach to where if someone has a strong goal, then you work with what their desire is.
Mm-hmm.
Yeah.
Great explanation. Wise words. Anything to add there, Dave?
Not a whole lot, to be honest. I think that it's. I think when it comes to these perspectives, there's so much nuance that's lost when things get oversimplified, and when things aren't looked at case by case. And I think one of the reasons why Kyle and I are friends, and why I've been referring to Kyle for patients for many years now, is when you work in the field and listen to the people that you're working with and actually listen to them, we all kind of tend to come to the same conclusions about things, because what is real is what is real. Otherwise, it's just delusional and not listening to things. And I think that when there's recognition that there's, I like to look at 5-alpha reductase inhibition like playing Russian roulette. And depending on what form you're going to use, the more bullets there are in the chamber. So if you're going to take like high dose oral finasteride versus micro dose topical dutasteride, you're looking at a very different chamber of your odds of having side effects. But as long as people are still, and maybe, and this is the thing that I am, I guess that I've learnt tonight, which I very much value, is that potentially it can be done in a way where it might not even be Russian roulette if you get hit by a bullet, because when I look at, the analogy of Russian roulette, I'm talking about post-finasteride syndrome in terms of like having side effects that don't resolve, because, Kyle's seen it, I've seen it, it's life ruining. And that's a very serious thing. But if there is a way to, if there is actually a way to have the cake and eat it too with this medication approach, to the point that side effects risk is so negligible that it would be comparable with, having a couple of beers a week, or, taking paracetamol and stuff like that. If the risk can become so low, I think that that's, not only a testament to the work that Kyle's doing in the field in terms of thinking critically and actually looking at things and, actually working out how this stuff works and applying it, but it may also give a really promising prospect to guys who need to psychologically have something done to manage their hair loss. And I think that's fascinating, and it's something that I'm very excited to look more into. And the thing that I would encourage people who've made it this far and listened to the whole conversation is looking at it and going, okay, well, there are still risks to all of these things, but if they can be minimized to the point that they're so low and someone's comfortable with taking that risk and working with and this is the biggest thing I'm going to say here, is work with a provider who can supervise this, because I haven't heard of this approach before. So if someone came to me being like, how can I microdose dutasteride? Like, well, I don't have a fucking clue. You need to book with Kyle. This is the kind of thing that's really important, is if people are going to go down this approach, like, you need to work with someone who's got the experience and perspective to be able to do this properly. Don't copy and paste this and do it with your windmill clinic and think it's going to work out, because there's probably a bunch of testing that Kyle referred to before that is nuanced in terms of whether this approach is going to work for you. So I've been saying for a long time that the person who comes up with the side effect free way to cure hair loss is going to be a very wealthy man. So if this is in fact, if Kyle has been able to find a way to make these medications significantly more tolerated to the point that the risk is so minimal that it's not a concern, and it can still confer efficacy, I think that's a huge testament to his work as a professional, and it's very exciting for the space. And I would hope that more providers will at least catch on to using the minimal effective dose to then be able to reduce, overall global instances of side effects. So I don't really have anything to add. It was a fascinating conversation. So yeah, thank you, Carl, for taking the time out of your schedule to talk to us about this.
Yeah, thanks, the both of you. It was very interesting. I guess a lot of viewers will take a lot of it. Thank you so much.
Absolutely. Thank you guys for the opportunity. I always try to apologize for how many times I talk about the prostate when I talk about TRT and 5ARs and things like that. So apologies to the listeners that are not suffering from those issues.